and I would like to welcome all of the George Washington students, all of our esteemed panelists, and all participants to this of our first lecture of this series. You can be engaged with the Africa Center for Strategic Progress in two ways. You can become a sponsor. We are a 501c3 organization, or you can become a member. So make sure that you check out our website and see all of the wonderful things that we have to offer. I would like to introduce Adadasola Adeni, who is the co-founder of the George Washington African Development Initiative. So Adadasola, if you could just, we've been working on planning this for a while, so I'm very thankful for Ms. Adeni. The format for this session is going to be, we're going to hear from our esteemed panelists, and then we'll have a question and answer period. We'll hope that you can keep yourself muted until we get to that question and answer period, and you're asked to take yourself off of mute. Wendy Apeng Daniels, if you could kind of raise your hand. Okay, she's a member of the Youth, Gender, and Vulnerability Policy Lab, and she's going to handle the chat box and the Q&A. So if you have questions during any of the panelists' speeches, then you can put those in the chat box. She's going to organize that, and we'll get as many questions answered as we possibly can. Okay, so again, I ask all the attendees to kindly mute yourself, and I am introducing Mawson Nyona. He's a graduate student studying public health. He's from Ghana, and he's at Johns Hopkins University. He's also a member of the Youth, Gender, and Vulnerability Policy Lab as the moderator. Mawson?
Yes. Hello. Good morning, everyone. I am Mawson Nyona, and I am delighted to extend a warm welcome to our audience and panelists. I am excited to hear from our panelists as they share their thoughts, unique insights, and impressions of issues pertaining to healthcare in the African context. Each panelist will have 10 minutes each to respond to a general question about their practice, and then we will open it up for questions from the participants. But before we start, I would like to introduce our panelists. First, we have Lauren Anvari, which there's a correction on the, we need to correct what was on the flyer. She's actually the program director for Soul Health, which partners with local and multinational organizations to promote quality health and disease prevention. Currently, their program engages with networks in the Gambia to strengthen systems on the community level. She holds a bachelor's degree in psychology from Goucher College and a master's in public health degree in maternal and child health from the George Washington University's Milken Institute School of Public Health. Next, we have Dr. Annette Taylor, who is a psychotherapist who provides individual and group coaching support, psychological assessments, neurofeedback, and trauma intervention. She's a member of the Healthcare Workers Care Network, which is an organization that provides mental health support to healthcare workers in South Africa. She is also a member of a broader network of health professionals responding to the incident of COVID-19 in South Africa. Dr. Taylor holds a bachelor's degree and PhD in psychology from the University of South Africa. And lastly, but not least, we have Dr. Kelvin Tamaklo. He is a primary care physician with a background in data science and healthcare consulting. He has experience working within hospitals and healthcare systems in Ghana. He holds a bachelor's degree in medical science and has a doctor's of medicine from the University of Ghana, and is currently pursuing a master's degree in public health and epidemiology from Columbia University. So I'll move it to our first panelist, Lauren, to present.
Thank you so much. Let me just queue up my slides here. Okay, are you all seeing this? Yes, I can't see you anymore, so please tell me.
Yes, we can see the slides.
Okay. All right. So thank you so much for having me. My name, again, is Lauren Varney. I work for a small Baha'i-inspired nonprofit organization called Soul Health, as was mentioned, and we work with discrete populations that have health burdens that can be prevented, and we focus on promoting health and preventing disease such that significant improvements can be achieved in the health status of those populations. And that can mean anything from a school to a city or even an entire country. Today I'm here to talk to you about the model we've developed for building collaborative and sustainable partnerships, and I will be focusing on our partners in the Gambia. But before I can talk about the model, we have to first explain how we go about selecting our partners to begin with. So, which is why we developed a 4-part selection criteria. And this is critical because if we have any hope of building strong and lasting partnerships, we first have to be very selective about who we partner with and the projects we take on. So we evaluate every entity that requests our partnership based on the following. First, feasibility. Is the project they're seeking our assistance on even feasible? We aren't going to waste valuable time and resources focusing on something that can't be done. And this might seem obvious, but you'd be surprised. We once received a request from a nursing home to help them ensure their residents would all live into their 90s. So clearly that's not feasible. Next is sustainability. We're interested in making a lasting impact. We don't only want to offer temporary solutions. So when we're evaluating a potential partner, we want to know if they have the ability to carry on the project after they're gone. And a lot of that comes down to buy-in and taking ownership, but I'll get more into that later on. So once we've established the project is in fact feasible and sustainable, we then ask, are our partners willing to share the results, good and bad, with anyone that asks? We have no interest in keeping our successes to ourselves. In fact, we don't even want any credit. Our partners never even have to mention us. We want everything to be freely available and the work we do to spread, which brings me to our 4th criteria. Whether for a variety of reasons, be it political, cultural, environmental, or social, if successful, is our project likely to be replicated? And the reasons for this likelihood will vary from place to place. So in the Gambia, we have several partners that have come together. First, we have UB1, a small German charity, who actually encouraged the Gambia Red Cross Society to apply for a partnership with Soul Health. When we received the request, to be honest, most of us had never heard of the Gambia and didn't even know where it was, which I'm sure is not a problem for many of you. Here it is, and it's completely surrounded by the Gambia River, and it's sandwiched by the Gambia River and is surrounded by Senegal. And it's in fact the smallest country in all of mainland Africa. Here it is again. As you know, maternal and infant mortality rates are strong indicators of the overall health of a country. So I just want to briefly compare the 2015 maternal and infant mortality rates in the Gambia to those in the rest of Western Africa, which is well known for having some of the highest rates on Earth. In the Gambia, the maternal mortality rate is 706 per 100,000 live births, whereas the average in Western Africa 618 per 100,000 live births. And the infant mortality rate in the Gambia is 68 per 1,000 live births, while the average in Western Africa is 60 per 1,000 live births. So clearly the need is there, But did these partners meet our selection criteria? Well, it only takes 6 hours to drive from one end of the country to the other. And with a population of only 2 million, the Gambia is a fairly small country. Therefore, even with limited resources, we felt that this project was in fact feasible. The Gambia Red Cross Society has over 20,000 volunteers throughout the country that live in the communities that they will be serving. Therefore, we determined this project has the potential to be sustainable. The next one is easy. Both the Gambia Red Cross Society and UB1 agreed to share the results with anyone that asks. And lastly, owing to the Gambia coming out of a 22-year-long dictatorship in 2017, the world was watching the country, and therefore we felt confident that should our project be successful, it would likely be replicated. So once all the selection criteria have been met, we then begin to focus on our collaborative model, which is comprised of 6 main parts. First, we establish the priorities, which it turns out can be rather challenging. It's important for sustainability that these priorities come from our partners themselves, as they know their populations better than we do. I pause here just for a moment to tell you a story. In our first meeting with the Gambia Red Cross Society, we asked them, what are your priorities? What are your areas of greatest need? And you know what they said? They replied, well, what do you have money for? And we were a little taken aback, and after a little bit of back and forth of this, we finally said, look, don't worry about the money. We don't have a stockpile of earmarked funds. We'll raise the money based on your needs. We just need to know what those are. And what they said next was really telling. They said, no one has ever asked us this before. It's clear that outside aid entities have always come in and told them what they were willing to fund. In other words, what they believe their problems are, rather than asking the people on the ground for those answers. So eventually, they came up with a whole list of areas that they needed help in, including infant diarrhea, pneumonia in children under age 5, maternal sepsis, adult depression, unsafe water supply, and open defecation, to name a few. Once our partners have determined their priorities, we then examine the literature to see what has been proven successful in similar populations. Based on this research, we then compile a list of evidence-based recommendations. Our recommendations need to be evidence-based because we want to ensure that everything we implement is backed by the science and that we aren't just experimenting with something that sounds good. We then take our recommendations and consult with the stakeholders at all levels of society, everyone from the Minister of Health all the way down to the regional councils and village leaders. This is the most time-consuming part of the process, but is also essential for creating buy-in and ensuring that our project is sustainable going forward. When we really take the time to meet with stakeholders and talk to them about their concerns, bring them into the conversations about the solutions, and hear their suggestions as to how they plan to maintain it after the project ends, they become far more invested and begin to view this project as their own, which is important for sustainability. And it helps us make sure that we aren't just repeating something that's already been done. After spending lots of time talking to the stakeholders, we then sit down with our partners again and adjust our recommendations based on the feedback and our partners' input. And that looks a lot like this. We spent hours and days in this conference room meticulously going over each recommendation and adjusting them to be truly tailored to the needs of the Gambian people. Now that we've just spent all that time meeting with all the stakeholders and building those relationships, getting endorsements, gathering support, and reworking our recommendations to reflect the feedback we received, we then consult all the stakeholders again. In the Gambia, there is incredibly high turnover of leadership, especially in the government. So we spent a lot of time revisiting our stakeholders and keeping them in the conversations about our plan. In other words, we just won't go away. And finally, after all that, In true collaboration, we're then able to develop a set of discrete initiatives that everyone from implementers to the recipients are committed to ensuring the sustainability of going forward. You see, simple 6 steps, right? The fruits of our labors have been well worth it. After 2 years in the planning phase, laying all that groundwork, we officially launched our project in February of 2019. And I can unequivocally say it was absolutely a result of strong and collaborative partnerships. And that's not to say we haven't had roadblocks and hurdles along the way. COVID-19 has definitely thrown us some curveballs, and we adjusted accordingly. Our general recommendations and initiatives are very modular, so we're able to take and remove as needed based on the needs of the people. So thank you so much. If you'd like to learn more about our project and this model, please visit Soul Health's website. Thank you.
Thank you so much, Lauren, on this great presentation. It was really refreshing to hear, the story that you gave about how you asked the individuals what they wanted instead of, the traditional paternalistic ways that things have been done in the past. So that was quite refreshing to hear. Thank you. So next we have Dr. Taylor. So Dr. Taylor, if you would present on your topic. Thank you.
Thank you. And with your permission, I'm going to do 2 things. I'm going to share my screen and speak fast. 10 minutes is quite something. Can you all hear me?
Yes, we can hear you.
And are you all able to see my screen?
Yes.
Okay. So I say hello to you from a beautiful Johannesburg in South Africa. And here we are at the tip of the bottom of Africa, a small portion. We're only 5% of Africa's total population. And the South African population is broken down into these segments. So I'm pink, as they often say to me. Sometimes they say that I'm pink with a black mind, but we are very multicultural. And what is so exciting is how we have left the shadows to a large extent of racial disparities, but it still plays out in the health sector, and that is what we're going to talk about. So briefly, just a few highlights from the South African story. On the 5th of March, a national disaster was realized in our country when the first COVID case was basically announced. And we relied a lot on guidelines from the World Health Organization. And what you see in front of you are key players that have collaborated very closely in this country and obviously with the World Health Organization to manage the pandemic. And in managing the pandemic, we have become increasingly aware of disparities and needs. And the National Institute for Communicable Diseases played a key role in forming a national emergency hub, call center. And what was quite exciting about our country was the readiness based on past experiences, which I'll show you now. So the Center for Strategic and International Studies, you probably know all about them, identified a few key successes from our president. And the first was leveraging past experiences, which has been our tuberculosis and AIDS campaigns. We started partnering with key players in the country and also throughout the world. We were able to do expanded contact tracing, identified key populations, and started doing 30% of the tests. Obviously, science-based approach was critical, and we had some very key pioneers who would, on a very regular basis, calm us, tell us where we are, and give us an awareness. And by April, May 2020, health experts had been supervising the mobilization of 28,000 health workers to screen more than 1 in 10 South Africans. So tapping into religious and non-traditional leaders is very much something we do in Africa. And we know that leaders in this continent and in sub-Saharan Africa have credibility. People trust them often more than their governments. So it was quite helpful in this country to access our religious leaders to play a huge role in the various facets of the evolving of this pandemic. And what was also new and refreshing was how our president managed to partner with political opponents. And this was quite good to help raise public awareness, create a united front, and actually lower oppositions. Now, I'm not going too much into this, but as the Center for Strategic and International Studies observed, we still have shortfalls, capacity shortfalls, low trust. And the third bullet point is very critical. The top 1% owns about 71% of the country's wealth, but approximately half of our population still live in poverty. And access to healthcare is a problem. And it's still a problem. And during the pandemic, these things were absolutely highlighted. We also have discrepancies between private hospitals and public facilities. And sadly, some of our more sophisticated equipment were accessed by more privileged hospitals. So now moving to my area. When the pandemic started, very early on, March, April, May, a group of very non-egoistic, giving people who served the community came together from various organizations and formed a team and started training volunteer psychologists, counselors, doctors throughout the country to provide free counseling and therapeutic support using some of the guidelines of the World Health Organization and other best practices. And a few key support groups also came together. This website at the bottom is very useful because there are so many free resources available even now that can take your understanding of healthcare to a whole new level. So the aim was to get all frontline workers and others to access emotional support. Whether you clean the floor in a hospital or perform surgeries or manage a COVID ward, if you needed help, you could phone in and one of us would start working with you. And this was quite exhausting, but also exhilarating because it's amazing what energy you get when you know that you can make a difference in a selfless way. And one of the models that successfully evolved was using team leaders and working through team leaders in hospitals that might observe that some of their staff need help. And there was also a telephone line. And we were very aware that different needs would emerge in the different phases of the pandemic. So there were webinars, training forums, opportunities to get ready to support people in the early phases, in the mid, the peak, the tail off. And the tail off was quite hard because in many hospitals, some of the doctors and nurses started becoming numb, saying, I can't feel empathy anymore. I'm so overworked. So we were trying to empower team leaders, connect people to resources, and use intervention strategies. We dealt with, I'm sure, symptoms that so many of you encountered in your different contexts, the many griefs that people experience, the difficulties, even in relationships. And if I can go to the second last bullet, what was very sad about some of our hospitals is that a lot of nurses went back home to unemployed husbands or partners who would engage in domestic violence. So South Africa had to draw on POWER, the Tears Foundation, Lawyers Against Abuse, but there were also a lot of informal strategies to try and cope with this. And it also made us realize that it's too easy to call somebody the bad wolf, when in fact those very unemployed partners also needed help. As in anywhere in the world, there were certain outbreaks and a dramatic, almost release of breath, which often happens in a pandemic as a counter reaction. So there was a consolidated direction on health and safety, which was a very useful guidelines and in fact had to be implemented in the workplace. Now I want to come to a main model of working. Some of you might be familiar with psychological first aid. When we work therapeutically with people, we often work with past triggers, emotions, traumas, and we pathologize. But when you work in a crisis situation, you don't go too deep. You get people grounded in the present. You make possible for them to feel that there's a compassionate and containing presence. You look at resources, at previous solutions. It becomes a very solution-focused way of working. All people need a sense of identity, health, and connection with others. And during a pandemic, those three needs are so highlighted. Some of us also helped the people we worked with to just get a sense of groundedness. You're tired, you have your own grief, you work long hours. So we did a lot of these techniques, and we actually afterwards often used one another to ground ourselves as well. The last point was not a psychological first aid technique, but it's a very recently developed neuroscience-based intervention in trauma, which a few of us used, and we were very, very grateful that it worked well. It's called brain work recursive therapy, where you work with the trauma event and a future memory. And we discovered that people can borrow hope from future memories. Some recent developments, we're working on our own vaccines now. We now have a loan from the World Bank to develop more. And a few days ago, the president announced that children at all levels will be able to return to school. And yet, 2 days ago, a new variant was announced. Isn't it dramatic? Just as things tail off, we get spooked again and we start catastrophizing. So let's see what happens to BA.2. Have you guys heard of it? I heard of it because I did my research yesterday and found it and thought, this is the slide I have to put up. And this morning, when I opened my social media, this was the information I had about how many cases we've had, the daily infection rate, deaths, and how many vaccinations we've had so far. I don't have much time, unfortunately, to talk about children and COVID, but it's so important to know that our children are growing up and they've gone through this trauma with us. And there's a lot of useful resources also through UNICEF and the World Health Organization. And one of the things that we found also work well is using existing stories to help children understand what is happening, like the story of the three pigs. And that is in my summary. So obviously the three pigs had to plan their journey and be ready to leave their safe place. And we were quite fortunate that the country had the infrastructure and the research bodies and the readiness to immediately jump in and prepare the facilities we needed to help with an unknown spread of the virus and how it would impact South African society. And in this space, there was no discrepancy between rich or poor, rural or urban. But there again, we live in a technological society, and people in remote areas who don't have social media facilities were not reached or were able to access the kind of help. It's the same thing. Collaboration was a key for President Ramaphosa's success, and we started thinking collaboratively. You know, this thing of heroes doesn't work, and you also don't want to be one of your frontline worker because there's certain expectations made on you then, and you're almost not allowed to be vulnerable. We became very resource aware, and psychological first aid and some of the techniques we used were applied to help empower not only our health workers, but certainly also people in companies and our own clients. Protection is not just about getting a vaccine. It's about internalizing and almost getting the wisdom and knowledge vaccine of what you are learning about yourself and others during this time. We started sharing stories. You know, I learned so much about people I would in normal circumstances never encounter because I became a voluntary service. I can also tell you that by the grace of God, I had an 82% loss of income during this time. But the reward I got from not earning and giving is worth every bit of money that I lost and more. I think we sacrifice the ego and discover something far greater. And we learn to release the shadow. Now, the shadow can be the shadow of despair. It's about taming the wolf, which is the virus, but also, in a sense, as we collaborate with people we normally wouldn't, even political parties that came together, we hear the other side. We go into open focus and we open up to new information. And in that way, we get transformed and we live in new wisdom. So we're ready for new challenges. Now, I've been very fast, and do you know that 9 minutes, I think, is that right? So that's what I have to say so far. Thank you very much. I'll stop sharing.
Thank you so much, Dr. Taylor, for your amazing presentation. You brought up so many things from race relations, class dynamics, and gender issues. And I'm hoping in the Q&A, you get to expound a bit on the impacts the pandemic has had on children. I think it's quite interesting, the social ramifications that children will have to deal with years to come. So thank you. So next we have Dr. Thamaklo, who will be talking about his experiences.
Hi, hello everybody. I'm Kelvin, and I'd primarily be talking about my experiences and using that as a prism to view the healthcare setup in Ghana, and in a wider context to view the healthcare setup in the West African sub-region. So I am a Ghanaian trained physician with my primary clinical experience in Ghana, and like I mentioned, I feel like that would be a good prism to view the healthcare setup in the wider West African sub-region because they mirror each other quite closely. And I'd be using this talk or this presentation, this contribution to try to answer questions around accessibility and then affordability of healthcare in the region. To understand the healthcare setup, it would be good to have a general idea of the administrative setup of the country and how health provision is given from an administrative standpoint. So structurally, the health terrain is structured as a form of an inverted funnel where we're trying to siphon patients from the periphery where healthcare is decentralized and maybe not as complex to a central core where there's consolidation of human resource and infrastructure to be able to provide complex healthcare. So at the very base, we have communities which are then aggregated into metropolitan areas or municipalities, also known as districts. And then districts coalesce to form regions, and then regions coalesce to form the national setup. All of this is handled under a unitary government. Ghana is run politically from a unitary government, and the implication of this is that healthcare administratively is run from a central point of view. So decisions made at the top are binding and carry all the way through, right from top to bottom. This setup that I've tried to describe from communities to districts to regions to the national level, just for purposes of making it a little clearer, is quite similar to the setup we have in the US, where you have census tracts aggregated to form counties, to form states, and then you have the federal government. Off the back of this build-up, we can say that the healthcare setup is built on these administrative divisions, so that at the very base, we have health facilities, which are really basic. We call them the community-based health planning services. They are the most basic of healthcare facilities for healthcare provision. And On the next higher level, we have health centers. Above health centers, we have district hospitals, and then district hospitals report to regional hospitals, and regional hospitals report to the national level, where we have tertiary and quaternary facilities. So I hope by this illustration, you've seen the inverted funnel picture I'm trying to paint, where we sort of siphon cases from the periphery to a centralized core. And this is done based on the severity of healthcare issues and the complexity of healthcare services that are intended to be provided. So the idea behind this setup is to promote an idea we call primary healthcare, which is sort of an indigenous solution to healthcare accessibility. In that, as much as possible, we try to decentralize healthcare based on need, so that in every conceivable part of the country, there's access to at least healthcare facilities. Beyond access to healthcare facilities, we have questions surrounding affordability and healthcare financing. So to sort of answer that as well, the country runs the National Health Insurance Scheme model. That's a nationwide health insurance scheme, primarily financed through premium payments from subscribers. Additionally, through social security deductions from formerly employed people, and then finally through a levy that's levied on all goods and services in the country. A percentage of all goods and services in the country is reserved for financing the health insurance scheme. So that forms a primary way of financing healthcare service delivery for majority of Ghanaians. Additionally, there's corporate health insurance schemes that cater to formerly employed people, and then the last bucket of healthcare financing is out-of-pocket payments, which poses a huge challenge for most people, as like the most needed and most severe or most complex healthcare services are usually priced out of the reach of most people. The stakeholders in the healthcare setup are primarily in three chunks. We have the public or the government-owned facilities, then there are the quasi-government facilities, and then the private health facilities. By quasi-government facilities, I mean institutions that are primarily government-owned, but then run healthcare services that do not immediately fall under the remit of the Ministry of Health or the Ghana Health Service. So these three buckets play a complementary role in providing a total healthcare service delivery in the country. So I hope that by these explanations, I have been able to demonstrate how the country is hoping to tackle the question of accessibility on one hand, and then on the other hand, affordability. It's on paper a system that's designed to answer many questions, but in practice, it's faced with a number of challenges. But despite the challenges, it has achieved a fair amount of success, and one of those was typified during the COVID crises, where the outbreak of the pandemic locally necessitated a need for decentralized healthcare service delivery. What we realized was that the setup that we had enabled care to be rapidly decentralized and instituted even at the periphery, so that cases were mopped up and then treated as necessary. It also meant that we're able to scale up and ramp up decentralized tertiary and quaternary facilities to become specialized COVID treating facilities, so that severe cases were promptly referred to where they could get the best bit of care. The best aspect of this setup has been that it's helped to preemptively tackle COVID, in that by virtue of the fact that it's all run under a centralized or unitary government system, decisions made at the top run through, and so there's a sort of a coordinated approach to tackling the healthcare issues that were necessitated by COVID. And this is in contrast with other areas where, like, perhaps a federal system of governance has not enabled the opportunity to have this sort of coordinated one view approach to tackling the pandemic. So that's an obvious success of the setup as we have it. The obvious challenges have to do with financing. as I mentioned, the primary model is through the National Health Insurance Scheme, but then there's questions around political will to use the scheme as was designed on paper or as was originally intended. So there are questions about misappropriation of funds and improper financing of health facilities. So those are questions that need to be tackled so that the health financing aspect of the healthcare setup as we have it or as I've described would be able to realize its full intentions. Other like other areas where this setup has been primarily of very good use has been through the surveillance systems for traditionally endemic conditions such as malaria and other communicable diseases. So again, because of the decentralized nature, it's helped to keep tabs on it's helped to keep tabs on outbreaks of infectious and potentially communicable diseases so that when localized outbreaks are noticed, then the cascade is initiated and necessary responses are put in place to prevent unwanted outbreaks of such communicable illnesses. So, in a nutshell, this is the setup that we're using in Ghana and widely mirrored through other countries in the West African sub-region, and that's how we've managed to go about tackling the questions of accessibility and affordability of healthcare and its representative challenges and successes. So basically, that's the presentation I have for today. Thank you.
Thank you so much, Dr. Tamaklo, for providing your insights. And I found it very interesting too how you brought in kind of the pivoting of the government to deal with COVID-19, because I think that's a really important topic. So thank you to our panelists for their presentations. And now we're going to transition to the Q&A section of the event. So to start off, I would just like to ask each of the panelists a specific question. So starting with Lauren, you kind of already spoke about this specifically in the context of Gambia, but are there, from your perspective, is there any like pressing issues across the continent? I know there is, the continent, it's hard to generalize a continent, especially a continent of this size, but are there any pressing issues across the continent other than mortality, maternal mortality rates?
Yeah, thank you so much. I can't really speak to issues across the continent. As you mentioned, there is such a wide range, and our work is really just in the Gambia, so I can only really speak to issues there. And three main things stick out. Access to primary healthcare is really limited, especially upcountry in the more rural regions. And then also access to clean water and proper forms of sanitation. Those are the three things that really stick out and that have really negative impacts on the health of the people. And we are addressing them in a multi-pronged approach. So we're first providing tuition and stipends for whole new cohorts of community health nurses. The Gambia has a really high attrition rate for their nurses. Once they've graduated, they either stay in the urban settings or they leave the country entirely, leaving the most vulnerable populations upcountry, the more rural populations, without access to healthcare. So we are sponsoring nurses, and then we are contacting them. They assign contracts, but when they agree to be sponsored, that they will then stay in a rural posting for a number of years, and we will be incentivizing them to do that so that they won't be so miserable, I guess. And our first cohort has just graduated, and they will be getting their postings in a number of months. So that's how we're first addressing primary healthcare. And for access to clean water, we are digging borehole wells that are solar paneled. solar powered, so that the communities really have a sustainable way to have clean water. And along with that, we are doing sensitization campaigns so that they know the importance of using this water. And the third thing is access to sanitation. And this is the one that we are just now beginning to start piloting. We were really stumped for a while about how to provide sanitation in a sustainable way to the rural populations, because in the Gambia, there really isn't any proper waste treatment facility. There's only one waste treatment facility, and that's in Banjul, which is on the coast. And it's just open ponds. Your sewage is dumped and exposed to sunlight for a certain number of days, and then it's put in the ocean. And so upcountry, where there isn't a waste treatment facility, even one as rudimentary as that, when latrines are filled, they either are emptied and dumped in the river, or they're just abandoned, and then people go back to open defecation. So we really care about sustainability, and we will be piloting composting latrines there. They've never been done in the Gambia, so we have to think about the cultural implications of whether or not they'll be used. It's going to require a sensitization campaign, but yeah, those are the three main issues that are really pressing in the Gambia.
Thank you for that insight, Lauren. Next, to Dr. Taylor, I just wanted to know, could you speak about some of your perspectives of health and disease prevalence in South Africa? And further, could you kind of talk about why the work you're doing with healthcare workers' care is so important?
Thank you. So obviously I am mainly involved in the psychological and neurofeedback world, but the pandemic has certainly more than ever highlighted certain inequalities, if I can start there. We've come a long way from where we were pre the new dispensation here, but there are several factors that make it very difficult for us to speak the same language about healthcare. In South Africa, as I suppose many places in Africa, we have the known health systems and modern health. But we also have a fascinating body of still untapped knowledge of traditional health. And there's often, especially in areas where sophisticated healthcare is not available, traditional healthcare. You know, the mind is very, very, very powerful, because now we know that the brain doesn't stop here but at your toes. So the brain is the whole body, and the whole idea of helping people to stabilize during times of crises and illness is to work bottom up before you can work top down. So in the healthcare, people who don't have access to very expensive hospital services and resources, and I'm not just speaking of our private hospitals, even government hospitals who are much, much cheaper and often free healthcare can be given. It's difficult to get there. It's expensive to get there. You also get a lot of alternative dynamics happening where people are exploring, going back to the periodic table, exploring different ways of thinking about health. So our healthcare itself is not equal. It's not accessible to a huge group of our population, but it does appear increasingly as if these other streams of traditional medicines are finding a voice, or trying to say we are legitimate in a different way. And you know, if you expect to be healed very often, your body often complies. So that's maybe not answering your question fully, but I have more than ever before been exposed to the power of this. When it comes to my area of expertise, here is another fascinating thing. Psychologists or healthcare providers working in the therapeutic industry often use language as an excuse to limit themselves to clients who can pay for their services But when the language is trapped in the body, you know, the whole thought of the body keeps a score, as Van der Kolk says, language isn't always necessarily only necessary. You can just sit with a person, and I'm talking about if somebody in a little township can get bandwidth to sit and speak to the psychologist because their husband's died and they're coughing and they're scared, and you can start breathing and singing with them. Now, we're quite a healthcare is an interesting thing when it comes to music and worship, because when people start singing together, even if it's songs of grief and songs of shared bereavement, a fascinating thing can happen. Fevers can be reduced. So in my own anxiety to make the difference that I understood I needed to make in my community, sometimes all I had was song. And I might speak to a woman in a place called Nchom, and she doesn't speak English, but somebody said, I do a lot of work with the Salvation Army, speak to this funny Taylor, and I'll say, sing something to me. And so we start using alternative ways of talking about healing and health. But my main feedback, and I suppose my main response to your question is, there's still a very big resistance between those that have to let go, have less, and give to those that have not. And you know, at the end of the day, this has become, for me, I'm speaking, this is my perspective, it's a moral issue. It's not sharing what we have. But we've made excellent progress. And now, with a lot of people having engaged across boundaries that they normally wouldn't have, new things are happening. The last thing I can say is that interns and healthcare providers, occupational therapy, speech therapy, that now do the community service, and doctors have to go to rural communities very often. And it's fascinating to see what incredible wisdom and healing they can facilitate. So there's movement towards that. Enough. Have I answered enough? Have I passed this test?
Yes, you have. Thank you. And I see that there is a question in the chat. I had a question for Dr. Tamaklo. However, I think this is a wonderful question to ask. So if Evelyn, would you like to ask your question to maybe Dr. Tamaklo? Or I can just repeat your question and address it to Dr. Tamaklo. Okay. So the question is, it was addressed to any of the panelists, but to you, Dr. Tamaklo, in your individual projects, how do you ensure that you are being culturally sensitive to prevent imposing kind of Western ideals or morals in furthering the colonization of the populations in Africa?
I think that's a really great question. It's very important, and thanks to Evelyn for asking that. I find that in my experience, right, an important part of healthcare service delivery is recognizing that the end product is not really what's important. It's not like the healthcare service you're providing that's important. It's who you're providing it to that's important. And that kind of approach helps instill in you a sense of cultural humility and in recognizing that your solutions aren't guaranteed to work unless, of course, they are tailored to the needs and like wants of to whom they are targeted. To achieve this, you need to, like Lauren mentioned in her presentation earlier, you need to find out from the people what it is they want and tailor your interventions according to that. And even while tailoring interventions according to that, there's even more like there's an even higher need of a sense of cultural humility in recognizing that despite your own experiences and despite your education, your Western exposure, and all of that, there's still a need to recognize that there's a lot of local expertise, even in people who may not have undergone the sort of formal training that you have had, and then recognizing that their opinions and their points of view are just as valid as yours. What you achieve by having this disposition is recognizing that the major influence for what you're trying to institute, the healthcare service you're trying to deliver, comes from the people that it's targeted to, and not from what you perceive as what is right. And by so doing, you avoid falling into the trap of imposing on them whatever ideals you have, which may have been influenced by other ideals, perhaps from where gathered from where you've trained or where you studied before, and all of that. So you are able to maintain a sort of local context to what you are like hoping to achieve, and that helps to eschew falling into the trap of further colonization of African populations.
Thank you for that. And so going along with that theme, I wanted to ask kind of, this is to any of the panelists and anyone who wants to participate in this discussion, but going along with that, I wanted to ask kind of what would you say is the narrative around African health? And in answering this question, kind of thinking about the dichotomy between like modern health and traditional African medicine, like what role does specifically traditional African medicine play in the overall health infrastructure on the continent or in your respective countries?
Can I make one comment?
Yes, please.
One of the very current research-based findings is that a lot that happens is inflammatory, even some psychiatric conditions, and that the inflammation, once you target the inflammation, you can actually promote health faster than a lot of these expensive drugs with side effects. And having spoken to a few people who have the one foot in the Western medical field and the other one in even practices of traditional medicine, would say that once you understand the herbs and the traditional medicines locally available that have a long tradition, a lot of these actually lower inflammation. So it's just a thought, because this is the latest. If you go to the website of Dr. Mark Gordon, TBI Help Now, tbihelpnow.org, you will see so many articles on neuroinflammation and now how we're rethinking many diseases and many mental conditions, PTSD even. So going back to herbs, there's an exciting new voice that's trying to come out here. I just wanted to say.
Thank you.
I would like to turn to a question in the chat, and the question is from Adida Sola, and she's asking about the issue of brain drain in relation to health care workers in Africa. So she starts off by pointing out the example that Lauren, you gave. So she's asking, are there any initiatives by the government to prevent that? And maybe that question can be directed to Lauren, but then it can be expanded also to the context of Ghana and South Africa with Dr. Taylor and Dr. Tamaklo. Yeah.
Sure. So yes, the Gambian government is in fact trying to address this. The first thing is that we sponsored this new cohort of nurses, and we doubled the class size. So we then had the government sign a contract with us that they agreed to take on their salaries once they've graduated. That's really important for sustainability. We don't want to be paying their salaries because what happens when the project ends. So we paid their tuition and their stipends, and then the government agreed to adopt them into the budget once they graduated. The second thing the government has done is they are in the process of building a much larger campus so they can train, I believe it's like 4 or 5 times as many nurses at a time. So of course, they're probably still going to have some attrition, but at least now they have a larger pool, so more will stay just percentage-wise in the country. And what we are doing is we are going to be piloting incentivizations for those nurses to stay in their postings longer. And it's really been a conversation about what would be most effective, what's going to be more sustainable. And what we're discussing right now is furnishing their dwellings with some creature comforts, primarily solar panels, television, satellite dishes, so they can feel more connected and they're not so remote and isolated in their little postings, but they can come home and they can relax, they can watch something, they can still see what's going on in the rest of the world. And that right now is what we are discussing, piloting in consultation with the local stakeholders. That was their suggestion. They think that this would be something that the nurses would really appreciate and would help them stay. And not only that, but once that nurse's posting ends and the incentivization package would remain in the dwelling, so it would be able to be used for over multiple postings. So that's how we're addressing it, and I can't say whether or not it's been successful because our nurses are just graduated, so haven't yet been posted in the field, but that's where we're headed.
All right, thank you. And I think Adedasula would be also interested to hear perspectives from the South African context and the Ghanaian context. So Dr. Taylor and Dr. Tamaklo.
I don't have any valid information to add, just observations. A lot of our nurses are being scooped up by our private hospitals. So it's an interesting, we've moved a lot from how South Africa was, but I'll give my other panelists a chance to answer that.
Right. I think that's another important question. And obviously, I'm not part of government, so I'm not sure what I can't really speak to, at least speak on authority, what it is that the government is doing to forestall this trend. But as a physician, I can probably relate to what I feel the push and the pull factors might be for this brain drain phenomenon, which we're actually experiencing in sort of twofolds. One is healthcare workers trained locally are like moving to the west for seeking greener pastures, and what constitutes greener pastures is a discussion we can have separately. And then secondly, even within the local context alone, within African countries, we're finding that healthcare workers are gradually getting more and more concentrated in urban areas, and not really working in rural areas where there's just as much need for their expertise in terms of delivering healthcare services. I find that it's like there's two major factors that's probably contributing to this. First, a sense of economic stability, because as I'm sure a lot of people may relate to, working in the healthcare sector is quite draining. So people want a sense of um, just reward, given how much effort they put in. So um, I feel like naturally people tend to gravitate towards where they feel like that reward will best match the effort that they put in. So that accounts for probably the pull factor for the expertise from the West. Additionally, in the Ghanaian context, for instance, the country is evolving a bit more and healthcare services are getting more and more complex. So there's a trend towards specializing and subspecializing for healthcare workers, from doctors, nurses, and other allied healthcare practitioners. So then, if the opportunities to further develop personal skills, personal competence, personal technical expertise is not there, if these opportunities aren't there in the required numbers to sort of absorb the demand, then people are naturally again going to gravitate towards where there's more of these opportunities so that they can sort of feel like they're maximizing their potential. So if I were ever in a position to advise government on what may be needed to sort of address some of these challenges, it would be this two-pronged approach, looking at economic remuneration for healthcare workers, and then additionally looking at providing adequate opportunities for people to probably specialize and subspecialize and feel like they're maximizing their healthcare potential.
I actually have something else to add to this point. One other thing that we've done is we've partnered with ECHO, which is an organization that builds hubs in country, that they'll help you build a hub that will then provide continuing education and peer-to-peer support for the nurses. So in addition to having nurses be in a, have incentives to stay, they will also receive continuing education from experts, but more importantly, be able to come together and have peer-to-peer support. So they will be able to share case studies and learn from one another, which will really help them feel less alone and that they still have that support ongoing. I just thought that was important to add.
Dr. Taylor, would you like to also respond to that question?
So it's probably the same question. And like Dr. Tamaklu, I mispronounced your surname. I don't work with government, but in the new South Africa, we obviously give preference to formerly disadvantaged groups and Black nurses in our private hospitals. So there's a huge rebalancing of nursing and healthcare provision opportunities. I also know that if there's a brain drain amongst people who find they can't get positions here, then it is really because they feel that they don't have a future here. But I have to be careful to separate my position. I do a lot of community work, so I have a community heart, and I might be moralizing if I want to pronounce on people that leave because they want to get economic value elsewhere. I just think we're missing a lot. I think we are missing so much by going away. They say bloom where you planted. And but then I might be moralizing, feel that you owe it to your roots to stay where you are and do your little bit, even if you have to give somebody else a chance. I don't know whether that contributes to anything, but it's not as sophisticated a response as the others.
It does, definitely. Wendy, are there any more questions or?
So there are not any questions in the 2 questions have been already answered. So is there anyone who would like to ask their question by unmuting themselves? Yeah, feel free. We are small in a group here, so yeah, it would be nice to hear questions from you directly. No. Well, throughout, so feel free to use the chat box, but so far, no.
So kind of on a related note to like the brain drain, in my studies, I kind of have concluded that there seems to be sometimes kind of over-reliance of African health systems on kind of foreign health systems. For example, I think the WHO stated that we're currently in a vaccine apartheid, where the global South has to kind of rely on the global North for their vaccines. So, in your personal experiences and on the ground, is that over-reliance like felt in terms of like pharmaceuticals, PPE, expertise? And if so, how do you propose remedying that?
Just a question, are we separating science now from, because presumably the debate is also about the vaccine is a Western thing. So what are we talking about?
I guess just talking about just like because I know I read places where like South Africa is trying to develop its own vaccine hub to develop vaccines for the continent. So just kind of discussing the importance of Africa developing its own capabilities instead of relying on foreign countries for various health components such as pharmaceuticals, PPE, and expertise. Because I also know typically in disasters or crises, a lot of foreign, healthcare workers will come in who may not necessarily know the specific cultural and spatial context that they're dealing with. And yeah, so just a discussion around that aspect.
In our country, we had a few corruption scams where we signed huge deals with locals who would bring in PPE and things, and the money disappear. I mean, that's the exciting challenge, isn't it? Let's do it ourselves.
So I guess in your experiences, do you guys think there is over reliance on other governments?
Yes, I think I can speak to this to an extent. Yes, there is an over reliance on like foreign expertise, foreign infrastructure, foreign frameworks to help provide healthcare service delivery locally. Um, but I guess it's sort of in a roundabout way, right? A sort of a silver lining to the pandemic is the sudden realization that there's a need to build local capacity. And this realization came about from the fact that the pandemic is such that there's demand for skills and input all across the world, all at the same time. So then, against the traditional setup where probably we are in need and others are not necessarily in need at some point in time, so they're able to provide support. Here's the case: at the same time, everybody needs to take care of their home. So like that drums home the need to build local capacity. And to some extent, I feel like local governments have started to rise to that challenge because the realization is quite stark, right? If you're not rising to that challenge, then you are perhaps doing yourself in. So I've noticed trends where um, there are attempts to build local capacity to provide pharmaceuticals in terms of vaccines and therapeutics and other such inputs. And then there's local capacity to build to provide materials such as PPEs and whatnot. And then, of course, there's the ongoing drive to build as much healthcare expertise locally as possible, so that we're able to galvanize our healthcare system as much as we can. So yes, there is an over reliance, but then also to put a positive twist to it, the pandemic has brought into sharp focus the need to build local capacity so that going forward we are able to better withstand such shocks.
Yes, I agree that there is, at least in the Gambia, an over reliance on outside aid. But I think in the context of the history of it coming out of this really long dictatorship, it's understandable that they're not going to be able to rebuild and get all their ducks in a row overnight. So it's going to take time. But soul health philosophy in any case is the earth is one country and mankind its citizens. So we're all part of this global entity, and really working together to elevate and to move each other forward is really, I think, the only true sustainable way, and where we can, raising the capacity and helping them achieve, but also just recognizing that we're all part of this human family, and we just seek to implement these ideals one project at a time.
Yes, thank you, Lauren. So there are two questions I can see in the chat. One from Sally, and Sally is asking, how are the youth in the continent dealing with their mental health? Like, how are they being met? So Sally, is it directed to a particular panelist? Would you like to ask the question yourself, or is that me? Oh, okay. So any of the panelists, yeah. Dr. Taylor.
So if I go to the slightly older youth, so with the online teaching, there's been a huge problem with screen time. And I don't know whether other countries on the continent are finding this as well. But because there's been a promotion of my life is through my screen, whether it's my teacher or my friends, I can't really play far outside. And we know that some screens actually are quite bad for one's theta brainwaves, and blue screens, I won't go into that. But some of the high school children had mental health issues that arose from them was nighttime, they're awake. They've made new friends, or they're part of support groups all over the world, and they're in different time zones. And there's been huge sleep problems. You even find it when you do neurofeedback or you get QEG results, all these delta waves where there shouldn't be. The screen time has become a problem because screen time also takes the place of what the youth often need to do in their development and play. No longer am I a superhero on the sports field during lockdown. I become a superhero through my gaming. And so that's become a concern shared by teachers and parents because it has a domino effect. So I'll just kick off and just say that.
I'd say, yes, there is actually a really big problem with depression, especially in men in the Gambia. And this usually stems from what we've learned or what we've been told from this feelings of not having worth or not having being able to contribute. And so, this sensitization campaigns that we are employing really employ the youth to have them go and serve their communities, to make them feel like they have an impact, that they are helping those around them. And I think really that's not the goal. The goal is not to impact the health for that initiative, but really I think that just being of service to others elevates mental health in general. So I think that that's having a positive impact, even though that's not the goal of that.
Yes, thank you, Lauren. And previously in the discussion, there was the issue of capacity building, and Dr. Taylor mentioned about corruption. So Evelyn is asking, how is the healthcare system in Ghana, but also South Africa and Gambia, how are they handling the issue of corruption and mismanagement of funds? How are the respective governments dealing with it? So, would Dr. Tamokle, would you like to come in?
That's quite a tough question to answer, particularly if you do not have insights into how exactly government is running its affairs. But from an outsider's perspective, what I probably would say is it's a matter of political will, right? If like the will to actually meet the needs of the people, and if there's that political empathy to realize that you're only in positions of power so that you can do what you can to better the lives of those who most need it, if there's that realization that that's what being like political authority is all about, then that sort of engenders the will to do what is right and eschew corruption and other such practices so that you can ultimately provide beneficial end products to those who most need it. But in terms of structural hard fact practices to mitigate corruption, I may not be able to speak to details, but I do certainly feel like it's a matter of political will.
All right, thank you very much. So I'm going to take one more question from Lydia, and Lydia, you'd like to ask your question in person. Yes, go ahead. Thank you.
Yes, hi. Thank you guys for joining us this morning. So I'm curious. I want to piggyback off Sally's question about mental health, and I'm curious, what would you describe, or how would you describe the approach has been to mental health within the African healthcare system, considering there's one side where in most African countries, mental health has been stigmatized as something that is just in your head, per se. But then there's the other side of it. To Dr. Taylor's point about there's been a lot of increased screen time, especially to the pandemic where everything is now virtual. But that's how a lot of youths have found passion in either coding or things that are likewise with the digital age. So how would you say the approach has been where there's, the negative side of just not addressing it to begin with versus the other side where it's possible that students are learning from the increased time they're spending on their screens and whatnot?
Isn't it an interesting double-edged sword? Because of course you're learning, but there are those silent adverse effects as well. You're passive. You've got, if you don't have a proper screen, we know with some of our ADD children, they have a lot of theta waves up here when they shouldn't have it, because even late at night, they love looking at their screens. It's often small little screens. And I think it's a problem if it's not balanced. I suppose all this online things need to be offset with, I have to get my body outside and breathe. I have to socially engage. There's a very different social engagement mentally to do what we're doing now. But if we think of the polyvagal theory and the importance of that myelinated vagus nerve near the pituitary gland that just releases oxytocin and can make you bond. You bond in a very real physical way, face to face. And of course, face to face is often mask to mask. So some of the youths that we deal with do a lot of online and they're depressed, either because their dopaminergic networks are not working or because literally they're stuck, they're tired, late nights. So it's a case of, I think, finding that balance.
All right, thank you. Then there's a question from Lillian, and she's asking whether there are any initiatives that are being implemented to demystify either traditional or religious myths around access to healthcare, especially around issues of mental health. Yes, so Lillian, would you like to address this question to a particular panelist? Otherwise, any of the panelists feel free to answer.
In South Africa, there's a language called Xhosa. I don't know how many of you speak it. And there's a word for a certain kind of spiritual madness called amamafufunyana. Have you heard that? And sometimes there's a trust thing with if somebody might have a psychiatric condition that could be neuroinflammatory based or whatever, that there's a common spiritual madness. So in some of our more rural or our more traditional hubs, there's still stigma. But the stigma is also trust. And if it's considered to be a spiritual malady or because of witchcraft, and witchcraft is a fascinating other topic to discuss one day, then it's very difficult to get mental health care in a reliable way. The other sad thing is mental health care is expensive. And psychiatric drugs with all their side effects are also expensive. And therapeutic and counseling services are expensive. And sadly, often you have a pastoral or a traditional or a church-based kind of voluntary free healthcare that might not actually do what it should do because these people are not diagnostically trained. So it's complicated.
Yes. Okay. Thank you. So I'm going to take two more questions that the two questions that are in the chat as we're getting close to closing time. So one question is from Adida Sola, and she's asking, so what resources, opportunities, and actions are available or would you recommend to engage young people both in the continent and also in the diaspora who are interested in service in the sector? Yeah, Lauren. Yeah.
Yeah, I think that any sort of social action service would be wonderful. I can only speak to what I know, and with Soul Health being a high inspired organization, I know that there are different social action service opportunities for young people worldwide that engage with like the sort of the spiritual and the community building work around young people, where they can both be in these groups together, and then these young, I believe it's starting at age 11, where they can come together in groups, and then they kind of have this more elevated discourse with each other, even starting at the age 11, around these big topics, around these big discussions. And then on the other side of that, they go out into the community and conduct service projects based on the need that they self-identify in their communities. And it's really wonderful seeing how they take ownership of this, and it really blossoms within them. And to go on with that, once they become older, and they are older than 15, then they start animating those groups of 11 to 14-year-olds. They start leading them. And it's just sort of this ever evolving and continuous cycle of these young people being brought together to have these big discussions so that they don't feel so isolated and alone. So much stuff is happening in the world, and I think just being able to have those platforms to discuss them together, but also have fun together, and then to really self-identify the needs of your communities and how you can then go about solving them has really had such a positive impact on these young people. So that, those groups are happening all over the world, and they are Baha'i inspired as well. So yeah, I'm sure that you could find those.
Yeah. Yeah, thank you very much. So one last question from Sally and she's asking, is anyone of you working with youth and storytelling, about youth telling their own stories? Yeah, and that will be the final question I'm taking for participants. So yeah, who would like to start?
Is the question, if I may just ask, groups of youth or storytelling as a way to empower and maybe debrief youth? Is it storytelling as a kind of an intervention? I just need to understand the question.
Sally, could you please clarify
Sorry.
the question? Yeah, so can have.
And Lydia, okay.
Okay.
I'm not sure if it's targeted at me or to explain her question, but I'm assuming she's talking about people who are like individuals who are experiencing mental health concerns and whatnot. Is there anyone there to tell their stories, or is it just more like stats and data that we're getting our information from? I'm assuming.
Can I unmute for just a minute to clarify? May I unmute?
Yeah, sure.
Okay.
Sally, yeah.
This is Sally. I just wanted to clarify. I was wondering if anyone is gathering stories about the students, what they have been going through, and maybe on topics of belonging, and also as a therapeutic. I'm a psychologist, so also as a way of helping them deal with their individual issues as they go through COVID. And over again, we have various different types of COVID that we're dealing with, and just wondering if anyone's gathering stories about that. I'm a storyteller. I love to gather stories, and I just wondered if anyone in Africa is gathering those stories.
I can address what we're doing. We have been collecting. Every time we finish a well or we're assessing a community, we do interview the inhabitants, and we get their stories on how they're impacted and how their lives are improved by having the water or the sensitization or even integrating the nurses. But I think having this echo hub in the community will really help with that as well, because then the nurses are going to be able to share their stories with each other. And I really love the idea of having this recorded more formally, Sally, so thank you for that, because I do think that that would be really valuable, not just for the nurses themselves that are participating in this, but then to share maybe more on a wider and broader scale. So I really welcome that, and I'm going to look into how we can implement that further.
Sure, I'd love to connect with you about that. Thank you.
Yes, thank you. That was wonderful.